Great. I think we can get started. Good morning, good afternoon, and good evening, everyone. Greetings from Malaysia, and thank you to everyone who's joining us from all over the world. A warm welcome to this session on safeguarding and advancing sexual and reproductive health and rights in universal health coverage on the road to the 2023 UN high-level meeting on UHC. This event is co-hosted by the Alliance for Gender Equality and Universal Health Coverage, Women Deliver, Women in Global Health, Sama Resource Group for Women and Health in India, and Spectra, Young Feminists Activism in Rwanda. I'm your moderator today, and I'll be first sharing some housekeeping items before I even tell you who I am, just to make sure everyone is able to engage and participate from the start. So interpretation is available in English, French, and Spanish. You can click on the globe icon at the bottom of your Zoom screen and select the language you wish to listen to the meeting in. It may also be helpful to select mute original audio. Auto-generated closed captioning is also available in English. If you click on the CC live transcript icon at the bottom of the Zoom screen again and select show subtitle. You can also pose your questions for speakers throughout the event by using the Q&A icon at the bottom of Zoom. And also just wanted to let you all know the event is being recorded in all 3 languages and the recordings will be shared. You should have received a prompt about this when you were logging on. So first of all, my name is Michelle Remme. I'm Deputy Director at the UN University International Institute for Global Health based in Malaysia. And it's a pleasure to be here with you today. Now, we're all here because we know sexual and reproductive health services and rights are core to our humanity, but they are not always prioritized in UHC plans and processes. Now, the 2019 political declaration on UHC was a milestone in our efforts to change that. But of course, the COVID pandemic has really changed the world in many ways, and it's made the momentum towards UHC even more pressing than it already was. So in this session, we'll begin with an opening and scene-setting remarks on why sexual and reproductive health and rights must be advanced and safeguarded in UHC, along with why it's critical to engage civil society in these processes. We'll also be hearing from 2 country case studies, and we will have time at the end for a question and answer session with the speakers, followed by a wrap-up. So we hope you will leave the session with a better understanding of the importance of and centrality of sexual and reproductive health and rights in UHC, better familiarity with the tools and best practices for overcoming challenges in integrating SRHR in UHC, and very concrete takeaways on how to center the voices of women, girls, and young people in all their diversity and sexual and reproductive health and rights in the design of UHC implementation plans. So we have a stellar panel of speakers for you today, and my role will be to speak as little as possible and also to keep us to time. So without further ado, I'm delighted to welcome Kathleen Sherwin, Women Deliver's Interim President and Chief Executive Officer. She will be sharing opening remarks to provide context for the progress made to advance SRHR in UHC so far. Much of that thanks to hard work and advocacy by civil society. She will also be speaking to what's needed going forward, particularly in light of the ongoing COVID-19 pandemic. So welcome, Kathleen.
Thank you, Michelle, and good morning and good afternoon and good evening, everyone. As Michelle mentioned, my name is Kathleen. I'm the interim president and CEO of Women Deliver, and I have the privilege of representing the Honorable Helen Clark today, Women Deliver's board member, who asked me to step in for her. She had a last-minute emergency. So really, on behalf of Women Deliver, a co-convener of the Alliance of Gender Equality and Universal Health Coverage, along with Women in Global Health, Sama Resource Group for Women in Health, and Spectra, Young Feminist Activism, thank you for joining this important dialogue on safeguarding and advancing sexual and reproductive health and rights and universal health coverage. The Alliance for Gender Equality in UHC is comprised of over 165 member organizations from 58 countries advocating for gender equality and sexual reproductive health and rights, or SRHR in UHC. It was created from a need to drive collaboration and coordinated advocacy for gender responsive UHC policies, programs, and dialogue, particularly related to SRHR. Since its conception in 2019, the Alliance has consistently advocated to put the universal in UHC in that UHC design and policy, decision-making and financing, cost structure and implementation must prioritize gender equality in girls' and women's health and rights, including the health workforce. UHC is grounded in the principle of leaving no one behind. But to achieve this, it is critical that the specific needs of girls and women in all their intersecting identities, especially their SRHR, are fully addressed and included within an essential package of UHC interventions. The 2019 UN high-level meeting on UHC, one of the Alliance's first advocacy priorities, set a foundation for the prioritization of gender equality and SRHR in UHC, and member states committed in the UHC political declaration to ensure by 2030 universal access to SRHR services and integrate reproductive health into national strategies and programs. So now, 2 years out from the next UHC meeting, we look to governments, funders, civil society, and other stakeholders to reinvest in SRHR as essential and central as to UHC. The ongoing COVID pandemic has strained health systems across the globe and disrupted delivery of essential health services. It's threatened momentum for achieving UHC and has detrimental impacts on sexual and reproductive health and rights. For example, data indicate that in 2020 alone, the pandemic may have disrupted contraceptive use for 12 million women, with an estimated 1.4 million unintended pregnancies across 115 low and middle income countries. We also know that although we're all experiencing the pandemic is not impacting all of us equally. The same is to be said for the pandemic's impact on SRHR, with those in low and middle income countries and girls, women, and underrepresented populations, including Black, Indigenous, and people of color, LGBTQI people, and other traditionally excluded populations, facing outside challenges to realizing their SRHR. As the world looks to both achieve the vision of UHC and build back better from COVID-19, we need implementation and funding that are rooted in equity, that reach those furthest behind first, that build up resilient health systems, and that are gender responsive, filling these gaps that have widened during the pandemic, and recognizing that SRH services are essential, not optional. As we've seen from countless cases, the role of civil society is crucial in delivering this. So I'm really looking forward to hearing from all of our speakers today on concrete actions on how we can make these goals a reality. So thank you, Michelle, and I'm turning it back over to you.
Thank you so much, Kathleen, for really kicking us off and setting the stage for why this is a critical moment for SRHR and UHC, why governments must reinvest in the commitments made in 2019, and why civil society organizations are critical partners in making the promise of UHC a reality. So thank you very much for those remarks. I now have the pleasure to introduce Dumiso Gatsha, founder of Success Capital NGO in Botswana and member of the UHC 2030 Civil Society Engagement Mechanism Advisory Group. Dumi will hone in on this aspect of civil society engagement and why it's so important, speaking both from the global perspective and from their experience working at local and national levels in Botswana. So over to you, Dumi.
Thank you so much. As a civil society engagement mechanism on Universal Health Coverage 2030, CSEM, we have heard from our members across the world how there was little or no involvement of civil society in national COVID responses, despite there being so many CSOs actively responding to the pandemic without being included in national plans and thus not adequately resourced. Civil society engagement cannot be an afterthought to preparedness, emergency, or business as usual. 2019's commitment to achieve UHC by 2030 couldn't be more important in times of inequity in health services, care, and access. The COVID-19 pandemic, reproductive rights rollbacks, deteriorated mental health, anti-gender ideology, the shadow pandemic of gender-based violence, migrant and conflict crises are all key determinants to the urgency for reaffirming and strengthening accountability on the commitment to UHC. Even more glaringly, Similarly, is the need to advance and ensure SRHR amidst these challenges. Key to this is social participation towards more equitable engagement of diverse and often left behind communities. One example is how civil society within the HIV response mobilized on integrating emergency, COVID-19 and SRHR referral services, such as my organization, Success Capital, has done in Botswana as a sub-recipient of the Global Fund to End AIDS, Tuberculosis and Malaria. This is amidst the closure of sexual reproductive services in facilities at the height of hard lockdowns and restrictions, even health budget reprioritization at risk of vulnerable groups under a now year-and-a-half-long state of emergency in Botswana. The handbook on social participation for UHC recommends and provides examples on how governments must create participatory, inclusive, and engaging spaces that ensure civil society and community representation in policy decisions and programming. Similarly, we launched the Healthful Advocacy Toolkit yesterday, a new resource detailing the basics of UHC and advocacy for it. While it is primarily targeted at CSOs looking to kickstart their advocacy for UHC, the information and tools are useful for all stakeholders. This, along with the recently launched Coalition for Partnerships for UHC and Global Health, is a good step for advocacy and accountability in advancing SRHR within UHC and the SDGs, as well as other commitments emanating from the Nairobi Forum or the ICPD +25 and the Generation Equality Forum. Success Capital's work with other national partners under a regional bodily autonomy and integrity campaign and broader advocacy efforts include engaging policymakers, traditional and political leadership. This signals the importance of movement building and solidarity through using common tools such as the Parliamentarian Guide to Achieve UHC, launched yesterday as well, a resource for reflections for parliamentarians to translate global commitments into concrete country actions. These all help advance engagement, accountability, and mainstreaming of SRHR at policy and programming levels. More importantly, for community organizations and civil society to collaborate and ensure SRHR in UHC. Thank you.
Thank you very much, Dumi, for these really insightful remarks on how civil society and social participation make health systems more equitable and more effective at achieving health for all, and also how we need to do better in our ongoing COVID-19 responses and our decision-making bodies and plans. Just for everyone on the line, there will be a question and answer session later, so please share any questions you have for Dumi in the Zoom Q&A box. Next, we will hear from Viloshni Govinder, a scientist in the Department of Sexual and Reproductive Health and Research at the World Health Organization. Viloshni will provide a WHO perspective on the importance of integrating SRHR and UHC packages, and will highlight some WHO tools that can be used by both governments and civil society organizations to facilitate this process. Thank you. Over to you, Viloshni.
Thanks. Thank you, Michelle, for the introduction, and thank you to the Alliance for Gender Equality and UHC for organizing this event. And also special thanks to Darcy, who's been working relentlessly behind the scenes in putting this event together. A quick introduction to the WHO Department of Sexual and Reproductive Health and Research, including the special program HRP, in which I'm located. The Department of Sexual and Reproductive Health and Research includes the Interagency Special Program on Human Reproduction. And collectively, the department and HRP provide leadership on matters critical to sexual and reproductive health, both in terms of norms and standards as well as research. I can go to the next slide, please. And over the next couple of minutes, I'll share with you the role that the department and HRP are playing in advancing sexual and reproductive health and reproductive rights within the wider UHC agenda. But before that, maybe let's just revisit some of the progress that has been made in this direction. Next slide, please. Thanks. So over the past 5 years, there's been incredible progress in this direction and moving the agenda forward. And these include global commitments in 2015, the adoption of the Sustainable Development Goals by the United Nations. In 2019, the UN High-Level Meeting on UHC, which reaffirmed commitments to universal access to sexual and reproductive health and reproductive rights, and in 2020, the Nairobi Summit on ICPD 25, which Dimi also spoke to. And in 2020, in terms of some of the guideline work, WHO launched the UHC Compendium of Healthcare Interventions. Now, the Compendium is a database of health services to support countries in developing their health benefit packages, which is a necessary requirement for directing policy attention to and resources towards priority needs and services. This database is critical for advancing access to comprehensive sexual and reproductive health at a country level, since we know, and there's sufficient evidence that points to this, that there is often partial inclusion of SRH services within health benefit packages. As well as in 2020 and 2021, the operational framework on primary healthcare and the recently published handbook on social participation for UHC both recognized and placed citizens and communities as being central to shaping the design, implementation, and follow-up of national policy planning and review processes. Next slide, please. I'll speak a little bit to our work on SRHR and how we are advancing this work within the wider UHC agenda. We work primarily, the department works primarily across 4 areas. These include the development of normative guidance to support countries' incorporation of SRH services within their UHC plans and strategies. Secondly, in terms of strengthening the evidence base to support national priority setting and decision making. And I'll speak to later the UHC Learning by Sharing platform, which we're working on. Thirdly, in terms of technical support and capacity strengthening at a global, regional, and national level. And fourthly, as important as the others, is through advocacy and dialogue, positioning SRHR as key to the success of UHC at the global, regional, and country levels. Next slide, please. I'd like to briefly speak to some of our normative work in 2 areas, namely the UHC Compendium and the forthcoming handbook for achieving universal access to sexual and reproductive health services in the context of UHC and primary healthcare, both of which provide specific guidance on the processes and the practical steps that are essential to integrating SRH services into national as well as subnational health sector policies and strategies. We do know that policy and priority setting processes related to UHC are complex, technocratic, and by implication, potentially alienating from communities and civil society. So in developing these guidelines, we've been guided by the need to demystify and make more accessible our guidelines beyond policymakers and decision makers to include all stakeholders, especially civil society. The slide that's up front, that's posted, includes examples of specific actions that government and civil society can take in moving this agenda forward. And common to both these guidelines is the call for stepping up our investments in resourcing and institutionalizing deliberative spaces that enable the full participation of all stakeholders, especially civil societies and groups that are vulnerable and marginalized, including women's rights organizations. And at a country level, this also includes ensuring public availability of information of what is included for SRH in health benefit packages to which people are entitled, including whether these services are free or not. We also need to think beyond the health benefit package. As we know, inclusion of services in a health benefit package does not always translate into service delivery and access to quality care. Quality care, as we know, again, is a complex concept that is understood and experienced differently depending on the stakeholders. For example, while healthcare providers may focus on the clinical and technical aspects of quality, communities and clients' perceptions of quality may be influenced by social and cultural concerns, and they place much more emphasis on the human aspects of care, including the attitudes of healthcare providers. Next slide, please. So staying on the topic of evidence, I'd also like to briefly tell you about a collaborative project with UNFPA, which is the development of the Sexual and Reproductive Health and Universal Health Coverage Learning by Sharing platform, which we refer to as the LSP. The objective of the LSP is to create an accessible online resource of implementation stories on SRH UHC integrations. The stories are short, not longer than 1,000 words, and focus on the SRH challenge, intervention, outcomes, and the learning. And the focus here is on communicating content that is accessible and can be understood by all stakeholders, including the general public. Next slide, please. That should be the last. So looking back and reflecting on what have been advances in terms of how we shape the agenda and move the agenda forward. As we look back, there has been unprecedented political commitment to UHC and SRHR and growing technical and normative tools for advancing both these goals. However, for real progress and to move beyond rhetoric and make access to comprehensive SRH, we need the following actions. One is advocacy for SRH integration in UHC. And secondly, recognizing that country ownership is critical and actions remain with national and local governments. And lastly, ensuring that the participation of all relevant stakeholders in priority setting processes, especially those that are hard to reach. Thank you.
Thank you. Thanks so much, Vilashni, for this really great overview and also for sharing very practical WHO tools and implementation stories to support the implementation of SRHR and UHC programs, but also laying out the complementary roles of governments, communities, and civil society in advancing this agenda if adequately resourced. Again, participants, if you have questions for Vilashni, please share them in the Zoom Q&A box. And we've come to the end of our first scene setting section today. We're about to move on to the next segment, which is really to hear from case studies from Nepal and Kenya on how the government and civil society have partnered on implementing SRHR and UHC. But before we do that, we have a question for all of you, and really to learn about your experience and what you've seen of civil society engagement in your respective contexts. As you can see here, the question is, how has your government engaged civil society to integrate SRHR in UHC? There are a number of options you can choose from. You can choose to go for multiple answers. Just from my perspective, the UN University, we host the Gender and Health Hub, and I just want to highlight that one of our main objectives is to consolidate evidence and learning on what has worked in the past and in promoting gender equality across a range of health policies and programs. And one of the consistent ingredients of success and really the drivers of change from this evidence is feminist civil society. And so I think that this really speaks to that point here as well. So please go ahead. You have 1 minute to submit your answers. Again, you can select more than one answer. How have you experienced the government's engaging civil society to integrate SRHR and UHC in your context and in other contexts? Give it a few more seconds, and I will let the host go ahead and show us the results when in a few more seconds. So, have you seen in-person open forums, closed stakeholder consultations, small group of selected participants like citizen panels, health councils, advisory boards, steering groups, other, or are you not seeing any engagement of civil society in these processes? We are closing it now. And there are the answers. So most of you have seen, well, the most engagement we are seeing is in terms of closed stakeholder consultation and our focus groups. And then the second top response is in health councils, advisory boards, steering groups. So there is this sense of participation in a range of bodies, of consultation bodies, possibly less in decision-making bodies. And we unfortunately still have 16% who are not seeing government engaging civil society in these processes, and some who are still 14% who are not sure. Okay, thank you very much. So we're going to hear from the country case studies to hear about countries where there has been substantive, meaningful civil society engagement and some examples of what that looks like, but also some of the remaining challenges going forward. So let's move on. Thank you very much for sharing your experiences from your contexts. Our next presenters are Mr. Jagadishwar Gimiri, Deputy Country Director at IPAS, Nepal, and Dr. Guna Nidhi Sharma, Senior Health Administrator and Policy and Planning Section Chief at the Nepal Ministry of Health and Population. So they will share their examples of how civil society and the government of Nepal have been partnering and have partnered in the past to advance SRHR in Nepal's UHC package. Jagadishwar and Dr. Guna, over to you.
Thank you, Michelle. Thank you very much. Dear all, warm greetings from Nepal. In my presentation, I'm pleased to share the civil society role in advancing sexual reproductive health and rights in Nepal, linking it with universal health coverage. Next slide, please. While talking about the milestones for sexual reproductive health and rights, we need to consider the ICPD 1994, before pre and post ICPD. In Nepal, there are in pre-ICPD also, the Nepal government has committed for health for all. So that were commitment, and Nepal government has prioritizing to expand primary healthcare services throughout the country. So ICPD provided an ample opportunity for civil society to be part of advancing sexual reproductive health and rights in the country. The post-ICPD can be viewed from the lens that Nepal has a very strong legal and policy environment for advancing sexual reproductive health and rights, with active participation and engagement of a civil society organization. We can take examples, for example, legalization of safe abortion services in 2002, and the inclusion of basic health services and safe mother and reproductive health as a fundamental rights in the Constitution of Nepal in 2015. And the Millennium Development Goal and Sustainable Development Goals added momentum for the government's vision for prosperous Nepal and happy Nepali. So next slide, please. The Constitution of Nepal mandates the engagement of civil society organization in the national priority area. SRHR is one of the key areas to engage with. The civil society are important actors in major coordination and decision-making bodies of government of Nepal, whether in regular program or the humanitarian context. And there are a list of committees that civil society organization represents together with the government authorities. Next slide, please. In addition to the the civic space, the non-governmental sectors or the civil society themselves also have coalition for discussions, sharing and preparation for common vision on the agenda among themselves. There are NGO Federation, Association of International Non-Government Organization Health Working Group, External Development Partners Health Group. There are other loose networks as well, we call Reproductive Health Rights Working Groups, and this is chaired by the chairperson of National Women's Commission, which is the constitutional body to oversight the actual delivery of political commitments to improve sexual reproductive health and rights among women and girls. Next slide, please. And if we look at the specific role played by the civil society organization, there are advocacy and sensitization is one of the important areas that civil society organizations are engaged with. CSOs are being engaged with parliamentarians, political bodies, as and when needed. For instance, from IPAS, IPAS is organizing policy discourse with the parliamentarians and women leaders to ensure the implementation of provision mentioned in the Safe Motherhood and Reproductive Health regulations, including local level governments and the subnational level civil society organization. And CVSOs are also providing technical assistance for policy program guidelines. A few CSOs are directly providing SRHR services as well. And there is space for CSO to pilot innovation ideas or in the field of sexual and reproductive health and rights. For an example, IPA supported government of Nepal to pilot sign-up lists to increase cafeteria choices for family planning services. Civil society are being engaged in joint monitoring of the SRH program since long in Nepal, and to support all levels of governments. And social audit, community scorecard are few examples that are in practice by civil society organizations in current scenario. So there are innovations in demand generation as well regarding sexual reproductive health and rights. Mobilization of social media to reduce harmful social norms and practices are some of the examples. Like from IPAS, we have designed the program to build agency among women and girls for hard to reach areas. We have developed selected women as natural leaders who increases awareness among SRHs at the community level, and also works as advocates with the local government to increase resource allocation from the local government in SRHR. So there are other strategies like engaging men and boys in place as well. So next slide, please. If we look at the like example of the civil society and government's joint initiation, there is an example can be taken as the COVID response activities that is being done recently. The civil society organization advocated for the continuation of SRHR services as we observed few evidences of closure of some services, service sites due to COVID responses. After discussion in, like series of discussion in reproductive health subcluster, an interim guideline on RMNCS services in COVID-19 countries has been developed, where CSOs played a crucial role during the development process. So after the development, CSOs supported in rollout of the provisions of RMNCS guidelines to health managers, service providers, and subnational CSOs for the continuation of the services during crisis. And the policy discourse are ongoing with the parliamentarian and political leaders. And in addition to that, alternative program approaches for service delivery such as teleconsultation, telemedicine, home-based services, etc., were implemented and documented. For instance, in the slide you can see the documentation of the experiences of the experience and lesson learned from rollout of RMNCS guidelines from 4 SRHR organizations. And this can be found in IPAS website. And the collective support was provided to government through different coalitions for COVID-19 response and continuation of SRHR services, and CSO supported in monitoring and documentation as well. Next slide, please. And while talking about the future course, yes, Nepal is doing well in terms of engaging civil society for universal health coverage and civil society for sexual and reproductive health and rights. There are still a few, like areas that we need to consider for future for better SRHR outcome. There is a need for continuation of policy discourses and sensitization to fully translate the high-level political commitment for universal health coverage and sexual reproductive health and rights at all levels of government. And the next will be the civil society are aid to have critical role to ensure policy provisions into action. Like policies are there, we need to focus on implementation of those policy provisions, focusing on marginalized and hard to reach population. And our joint effort is must for the inequalities, like an increasing access and utilization. So the civil society need to plan and promote social accountability. We need to ensure the multi-sectoral responses. Thank you very much.
Thank you very much. Over to you, Dr. Guna.
Thank you, Michelle. Thank you, Jagdish sir, for the comprehensive presentation. Distinguished delegates, ladies and gentlemen, namaskar. On behalf of Government of Nepal, Ministry of Health and Population, I would like to express my sincere gratitude for inviting Nepal as a panelist in this important event. Nepal has made remarkable progress on sexual and reproductive health in terms of policy environment, service access, piloting and scaling up the innovations. from 1996 to 2016, Nepal has been able to reduce the maternal mortality ratio from 539 to 239 per 100,000 live births. Likewise, during the same period, the neonatal mortality rate decreased from 58 to 21. Under 5, child mortality rate declined from 118 to 39 deaths per 1,000 live birth. The total fertility rate declined from 4.6 to 2.3 per woman of the reproductive age. The adolescent fertility rate dropped from 127 to 88 per 1,000 girls of 15 to 19 years of age. The Constitution of Nepal has enshrined basic health service and reproductive health rights of the women and girls as fundamental rights. Nepal is among few countries in the world to enact the reproductive health specific rights. The Act has ensured accessibility, availability, and quality safe motherhood and reproductive health service to all women of Nepal. Moreover, Act has also prohibited to conscientious objection, forceful use of family planning services as well as abortion, sex selective abortion, and any kind of the discrimination on the basis of any kind of socioeconomic and other similar ground. The prevailing national health policy and 5-year periodic plan are directed toward achieving the target set for the sustainable development goals, and the strategies are focused to achieve universal health coverage. All these legal and policy arrangements are the result of high political commitment and strong voices of the civil societies and community people. Nepal has been adopting comprehensive approach to streamline primary healthcare services at grassroots level, recognizing the importance of the women's participation in promoting health of the people. Nepal initiated the Female Community Health Volunteer Program in 1989. And now the network has been expanded throughout the country with nearly 51,000 female health volunteers. The major role of the female health volunteer is to advocate healthy behavior of the mothers and community people, to promote safe motherhood, child health, family planning, and other community-based health promotion activities and service delivery. The female community health volunteers and mothers groups have been considered instrumental to bridge the community people with the public health systems. Safe abortion service was legalized in 2002 and service started since 2004. Safe abortion service has been expanded to the basic healthcare centers, ensuring service access to at grassroots level. Up to now, around 1.3 million women have received the services. Nepal has well progressed towards strengthening the health service delivery network in each of the 753 municipal levels and their 6,743 wards. Recently, Nepal has initiated to establish the fertility service clinics, including in vitro fertilization service at public health facilities, the cervical cancer, breast cancer screening programs, and rolling out vaccine against human papilloma virus targeting the adolescent girls are some of the recent initiatives to improve the reproductive health. Some schools have already implemented one school, one nurse policy, which is expected to provide adolescent family services at schools. Free distribution of the sanitary pads at schools is another initiative from the government. Considering the higher proportion of the financial hardship to the service utilizers, Nepal has expanded health insurance program throughout the country. Other social health protection schemes are in place to reduce the financial barrier to access healthcare services, such as through demand-side financing for the safe motherhood services. Institutional delivery is encouraged by providing the transportation cost for mother traveling to the health facility for delivery services. Nepal has been implementing sexual and reproductive health services through a collaboration and partnership with the various national and international non-governmental organizations, private sectors, and community-based organizations. Although overall progress in the sexual and reproductive health so far is encouraging, the unprecedented COVID-19 pandemic has overstretched capacity of the health systems, which has adversely affected some of the key health indicators. However, the government has reoriented service delivery mode in the context of pandemic to continue sexual and reproductive health services. We still have the unfinished job. The progress in reducing the maternal mortality ratio and reducing the unmet need for family planning service are stagnant. Moreover, there is still disparity in utilization of the service according to the woman's economic status, educational attainment, area of residence, and other socioeconomic covariates. Although in decreasing trend, the adolescent fertility rate is still high, though the total fertility rate has nearly reached to the replacement level. Certain groups and communities lag behind in terms of assessing the modern contraceptive services. We need to put extra efforts and devise innovative strategies together with the civil societies in reaching the unreached groups such as persons with disability, adolescents, sexual minorities, and urban poor. We need to strengthen monitoring and evaluation mechanism to examine whether our policy and programs are well implemented, reaching to the unreached sections of the society. For this, we need disaggregated but robust data through integrated information management system to capture relevant equity and equality data, which can further inform us to redesign the service network accessible to all needy people. Thank you. Over to you, Michelle.
Thank you very much to both of you, both Jagadishwar and Dr. Gunnar, for this incredibly rich set of lessons and achievements from Nepal in advancing SRHR in UHC, and also just for highlighting the breadth of the roles played by civil society and the multiple institutionalized mechanisms and spaces for engagement and participation, but also sharing the adaptations that have been happening during the COVID-19 pandemic and reflecting on the challenges and opportunities to sustain efforts going forward and ensuring accountability, really to leaving no one behind. So thank you very much. And I also just want to appreciate from all speakers that you are sticking so diligently to time. That's much appreciated and will give us enough space later on to have a discussion. So again, participants, please do share any questions you have for our speakers in the Zoom Q&A box. We'll now move on to our next speaker, Melania T. Jacqueline, who is Program Officer in charge of Community Empowerment with Kefeado, the Kenya Female Advisory Organization. Melania will touch on what civil society engagement in Kenya has been like, and particularly for advocacy and policies around young people's sexual and reproductive health and rights. So welcome, Melania, over to you.
Thank you very much, Michelle. I'll be talking about UHC and SRHR in Kenya and in conjunction with the youths and how much we are involved as youths from different parts of Kenya, from western part, the eastern, the central, and the Rift Valley. Thank you. Next slide, please. In my introduction, I'm talking about Kenya has the most youthful population around the continent, with over 70% of the population engaged age below 35. It is important to note that as youths, we are committed in UHC. We can also help push policies at different levels that improve the quality of service of SRHR and well-being through UHC. How we need to engage policy makers through implementation of UHC and also process the need of inclusion and diversity. There's need to talk about UHC, SRHR through peace and security, where need to ensure emergency pathways, which we actually don't have. And we need to also establish at all levels, now that we are nearing the electioneering period as a country. There's need to look at our budget on a more gender responsive manner. As an organization, we have been able to be privileged enough to trade community and the county assembly of Kisumu on gender responsive budgeting. And it doesn't stop there. It needs to be a long-term sustainability. And how do we do that? Next slide, please. We also need to have quality SRHR under the mental health. The data is clear that mental health services should be integrated into youth-friendly, accessible, and SRHR services. Data has also shown an increase in young people and adolescents living with sexually transmitted infections who are experiencing physical, mental, and social changes, especially this time of Corona. We need to talk about adolescent mental health and at all levels without being judgmental, and engage with them through quality comprehensive sexuality education. And this, as an institution, we have managed to do this through our Orange Wednesdays Club in collaboration with schools and the ministry. So that this shows that we are clearly working with the government in all aspects. As an institution, we have been able to support the health department in training persons with intellectual disability. Most of the time, they are always left behind, and no one talks about intellectual disability. And we have been able to bring them on board and gendering their views on Srhr in regard to mental health and inclusion of service delivery in regards to information and sustainability on the same. Next slide, please. How do we ensure this meets the need of the youth? As a youth, I'll say that we need to be engaged in decision-making and implementation processes, which is very critical and key. We also need to engage in creating awareness and delivering UHC agenda. I'm very sure most of the youth actually don't understand what the UHC agenda is all about. And that's why we need sensitization on UHC and health education in all aspects. And this, we are talking about community engagement, we are talking about schools, we are talking about higher learning institutions with the help of government. Now that government is a long term, and as CSOs, we are just here in a phase that we might phase out soon. There's need to create a safe and youth-friendly environment at healthcare facilities. You'll find that most healthcare facilities actually are not youth-friendly. So how do we create these services? There's need for us to have partnership in developing and implementing evidence-based programmatic responses by ensuring a conducive policy environment and coordinated implementation framework in all aspects. And that's why I was talking about youth-friendly and healthcare facilities. There's need to having persons with disability at the table to have their agenda discussed, especially women with disability who are of reproductive age. And this, I'm so passionate because when we look at most of our healthcare facilities, if I am having any type of disability, be it physical or I'm having hearing impairment, if I am to go to a healthcare facility, I will not have a sign language interpreter. And if I am physically disabled, if I am to go, maybe I'm going to give birth, you'll realize I'll still use the same bed as the other people who are physically able are using. So that's why we are saying that we need persons with disability on the table and at the table to talk about their own agenda and issues. Next slide, please. Youth need to be in decision-making spaces. And from the previous slide, I said yes. We need intergenerational dialogues and intersectional movement building, which should be key agendas in addressing UHC and Srhr. We don't want things to be made for us, but we want everything that we say to be implemented in different aspects. We also talking about building capacity of youth champions on sustainable demand and having meaningful youth engagement, which is key, especially where the government is involved in pushing the agenda. As youths, I say it's our time to engage. Let's create more awareness. Thank you so much.
Thank you so much, Melania, for your thoughtful reflections on meaningful youth engagement and for really underscoring that the importance of intergenerational dialogues and intersectional movement building as really critical agendas as we address Srhr and UHC. So again, participants, if you have questions for Melania, please do share those in the Q&A box. We have now concluded the presentation section, and I'm really sorry that we didn't have more time, but there was so many rich insights and compelling examples and very concrete examples of how countries and groups have been working together and how they've really been able to effectively, meaningfully engage civil society in these processes with some very real and concrete results for sexual and reproductive health and rights. So we now have some time to dig into that a bit more. Please do continue sharing your questions. We'll field through those. We will start off with some questions that we received before today's event from participants, the ones that were sent in. So I'm going to start off with Viloshni. If you want to turn on your video as well. The question for you is in light of the ongoing COVID-19 pandemic, why is SRHR a priority, and including for UHC packages?
Thanks for that question, Michelle. I mean, I think that's probably it's a question that kind of is at the top of all our minds. And I think the pandemic, has obviously taken a huge toll, but also a very important toll on gender equality and sexual and reproductive health across the world. It's also, as we know, laid bare and amplified pre-existing challenges, including gaps in the health system, gaps in social protection, vulnerabilities and barriers faced by women, girls, marginalized and vulnerable groups in accessing services. Melania and Dumi have spoken to groups around disability, different gender identity. And these challenges existed before COVID, were just amplified during the pandemic. And we've also witnessed widespread losses in access to SRH services, including family planning commodities. This has, Kathleen spoke earlier about the consequences for unplanned pregnancies. Also, what we've seen is increased levels of gender-based violence. And as Dewey mentioned, the shadow pandemic of the shadow pandemic. And at the same time, the pandemic is threatening commitments at a time when sexual and reproductive health and rights funding should be and has to remain a priority. And we've seen cuts in funding being diverted. But at the same time, I think there's also been some important learnings from the pandemic, which are critical for building back better. The pandemic has highlighted the importance of better prepared health systems that can offer uninterrupted essential services for women and girls when they need it most, including services for victims of gender-based violence. We've also seen that services that are not critical, that are not regarded as essential, many of which are SRH related and excluded from benefit packages, have been deprioritized in the pandemic response. But with every pandemic and every crisis, there's also a silver lining. And what we have seen during the pandemic is that certain governments and certain states have stepped forward and relaxed some of their laws around access to sexual and reproductive health services. For instance, making available the morning after pill, for instance. And strengthening health systems, we know is recognized as essential for ensuring safe, decent working conditions for female health workers who make up the majority of the health workforce. And I think all of this collectively, as Kathleen said earlier, SRH is not an option. It's an essential component of universal health coverage. And this lends even greater urgency to the quest for UHC, and also ensuring that universal access to SRH services needs to pay very specific attention to barriers that women, girls, marginalized and vulnerable groups face as we build forward and build back better. Thanks, Michelle. Thanks,
Viloshni. Thanks for highlighting also the innovations, the adaptations, and some of the silver linings of the pandemic. I have my next question is for Dumi, and it is around if you can speak to how these aspects of integrating SRHR and UHC and ensuring meaningful engagement of civil society link to other mechanisms like the Generation Equality Forum that are really aimed at advancing the health and rights of all individuals. And if you want, in your response, if you want to pick up on anything Viloshni said, or you want to build on anything, feel free to do that as well.
Great, thank you so much, Michelle. I think it hasn't been, it's more important now to adopt intersectional leadership, feminist leadership, and in recognizing that bodily autonomy and integrity are central to health and rights, and that SRHR is deeply structural and systemic. The lack of inclusion for diverse communities, variant forms of violence, and narrow determinants such as language, service and care packages, and ableist infrastructure reflect how patriarchal many SRHR policy and programming frameworks are. UHC underpins safeguarding and strengthening the rights of all people in their diversity, whether socioeconomic rights are justiciable or not, thus linking to other policy commitments, treaty bodies, and special procedures, particularly for dialogue, accountability, and avenues to sort of improve health outcomes. And I think this is inclusive of safe abortion, family planning, contraceptive deployment, HIV prevention and treatment, targeting queer young migrant survivors of abuse living in poverty. And I think including multiple vulnerabilities ensures that all people's aspirations and not just needs are addressed and aligned within the context of the decade of action. So that means engaging communities in feminist leadership, adopting intersectionality to ensure that those with multiple vulnerabilities are essentially included. I think it's really quite simple. And I think maybe just to sort of address some of the more broader issues is really then speaking to having improved ways of accountability, especially around budget processes. I can give one example in global spend being less than 3% on mental health. And this is quite reflective in terms of availability of data and the ability to actually see where governments are allocating funds for public health, and more particularly SRHR. And one example is for us, at least at a country level, engaging in an SRHR accountability process to not only strengthen our own knowledge by adopting some of the tools that I've mentioned that CSEM has essentially created or endorsed, but also sort of integrating other work within regional networks that exist, and sort of drawing from that and trying to investigate, but what are the avenues, be it through the National Development Plan, annual state budget processes, or possibly other avenues of soliciting information to ensure that we're able to keep not just national government, but the service delivery practitioners, the health practitioners, and the technocrats that end up sort of deciding which resources are deployed where at a local municipal government level. Thank you.
Thank you, Dumi. There's so much in there, but yes, I definitely on your last point about accountability and ensuring identifying the right entry points and getting that advocacy, making sure that the advocacy influences and it is part of the accountability structures, I think is really critical. Thank you so much. I'm going to move on to Jagadishwar. We've got a question for you, which was on the role that civil society can play in ensuring the implementation of policy provisions, drawing on your experience in Nepal.
Thank you, Michelle. I think the role of civil society is very important to ensure the access to universal health care, focusing on SRHR and other healthcare services. The first and foremost, there should be a political commitments from the national government, and the civil society need to be very active to ensure that it is in according to the commitment made by the government. So on that line, there should be access to service and and utilization as well. And we need to be cautious for quality of services and addressing the inequity in the access to the sexual and reproductive health and rights. So CSO need to be the kind of monitor, third-party monitor for to ensure that. So in addition to that, from the civil society organization, we might need to provide a continuous advocacy, to make the duty bearers and the service seekers responsible and accountable for the timely adoption of the services. And in addition to this, the coalition among civil society organization is also very important to put the agenda forward. I think this is something we are following in the context of Nepal as well.
Thank you. Thank you very much, Jagdishwar, and yes, for highlighting that social accountability role to monitor quality of care as well. I think many of you have picked up on the very many different roles that civil society plays and can play, and I think it's a critical thread that I'm seeing throughout the session that governments can engage with civil society as experts in many different capacities, but also as representing and holding them accountable. So Dr. Guna, I've got a question for you on what the advice you would give for how other governments can integrate comprehensive SRHR and UHC and how they can include CSOs in this process. And feel free to pick up on anything others have said if you want to build up that.
Thank you, Michelle. Based on our experience, comprehensive primary health care approach is instrumental to integrate the comprehensive sexual and reproductive health rights. So we can streamline all the services from the grassroots level to the higher specialized service centers. Civil society organizations have crucial role to raise awareness and bring public voices in the public forum so that the core issues are recognized and addressed by the policymakers. The civil societies can also monitor whether the policy implementation is on track or not. Nepal has been practicing engaging the civil societies from the very beginning of the policy development process and progress monitoring, such as annual reviews. We engage all the civil societies and community people while we are doing the review, for example, performance reviews. So these are also crucial. And schools, I think schools are the primary points for creating awareness on the sexual and reproductive health rights. Therefore, Nepal's focus is to strengthen the school health program, including this sexual and reproductive health rights through the school. Thank you.
Thank you so much. So for other countries, engage with civil society early from the start and throughout the policy design and monitoring and evaluation processes. And also really that multi-sectoral, the importance of the multi-sectoral approach and building off primary healthcare and schools. Thank you. And Melania, the question I have for you is, what are ways that civil society can engage the government over the long term around SRHR and UHC policy and implementation?
Thank you very much, Ms. Michelle. One, we need to hold government accountable for all the policies that are put in place. If we acts that are in place, we need to follow up and see if the policy about being put in implementation. We also need to do good advocacy. We need to have a targeted advocacy at different levels. And it should not be a one-time thing that, yes, the government did this, so we are now contented, then we wait till another 6 years or 10 years, then we start blaming the government as civil society. We need to put government on toes, because at the end of the day, we are talking about people getting these services, these services being implemented, and it should not only be at the higher levels, but it should trickle down to lower levels so that everyone is involved in the process. And you see, civil societies cannot do this on their own. We also need the help of the community to enable us to do this. Because at times you might think this is what the community needs, but actually they need something else from what you actually thought they needed. So we also need to see, how do we bring this together? How do we talk about governance? How do we talk about data? Because that is very critical to inform the decisions that need to be made at different levels. So are we talking about budget allocations? Or if we are talking about budget allocations, how much is being allocated at healthcare? How much is being allocated for sensitization? How much is being allocated? Like, we need to have a clear framework in addressing every issue so that we don't say that government is not doing, but we call ourselves as a collective to bring everything on board. And we also need to talk about sensitization and advocacy with other different people. We also need to talk about comprehensive sexuality education, which is missing in all aspects of life. So how do we bring this on board so that when we say we are holding someone accountable, we are holding them accountable for something that we need in different spaces. We also need to say, if we are talking about inclusion, how many people are being included? Because you see, I'll say in most spaces, we find that we live in a patriarchal society, and when decisions are being made, male are the ones who will be dominating. So if I am to talk about abortion, UHC and Srhr, I'll be told like it's not something that we should be talking about in the open. So how do we bring all this in a space that we are free to talk about it? And in a space that implementation needs to take place. Who are we going to hold accountable? How much is being allocated for this? And who are the people who are in this space to talk about it? Thank you.
Thank you. So many critical points. And I think it leads very well into a question that keeps coming up in our chat. And I wonder if others want to reflect on what you've just said as well, and links a bit to what Dumi was saying, around this need for accountability to budgetary allocations. The question is that implementation of UHC clearly calls for significant budgetary allocations, especially given the spike we've seen in demand as a result of the pandemic. And you know, when we do incorporate SRHR services in UHC. So how can we ensure sustainability of SRHR under UHC in resource limited settings? And by this, I'm sure that also thinking about a comprehensive set of SRH services as part of UHC. How do we make that sustainable? And if anyone wants to pick up on that, but also the question around the budgetary allocations and tracking those and better understanding those. Please, anyone who wants to jump in on this. Dumi, go ahead, I see your hands up.
Thank you. I think, two elements. I think the first is recognizing and acknowledging that there's a need not just for gender sensitive budgeting, but feminist budgeting. And so that means reprioritizing military spending. That's one, towards SRHR. Secondly, I think it's also in curbing illicit financial flows and recognizing that, corruption and other forms of, maladministration actually deny vulnerable groups, women and girls in their diversity from equitable and meaningful SRHR. And I think, from a second standpoint is, strengthening and allowing for community organizations, community-based organizations, feminist collectives to essentially address the needs and the aspirations of their communities. So being able to include them within the context of SRHR, being able to advocate and help enable them in contributing in policy making, but also in service provision to ensure that, the responses in terms of some of the challenges in unintended pregnancies, the inequities that exist around issues that compromise bodily autonomy and integrity can be led by and that they can serve the affected communities. Because I think this is the only way you can be trauma informed. This is the only way that you can strengthen safeguarding within the context of health responses and the inherent power dynamics that many vulnerable groups experience, not just at household or even community levels. And I think essentially it's ensuring and safeguarding that intersectionality can actually strengthen the sustainability of this. And it's weaving in all these different elements, because I know SRHR discourse doesn't often speak about demilitarization. It doesn't often speak about, alternative financing mechanisms or ensuring that illicit financial flows are curbed. Thank you.
Thank you. I could not agree more. I'm going to hand over to Vilashni to jump in there.
Just to add on to Dumi's points, Dumi, completely 100% agree with you. And I think probably just to add on to that is also understanding how we can, in many contexts, with existing resources, how do we do better in terms of providing quality care and strengthening the integration of sexual and reproductive health within a primary healthcare approach. So there's considerable now, increased focus and attention on primary healthcare as the cornerstone for UHC. And we know that SRH is services are compatible with a PHC approach in terms of engaging communities, empowerment of communities, working across sectors, and that SRH services are largely preventive, promotive, cost-effective, and can be delivered at a primary healthcare community level. So I think within the key arguments is one is let's advocate for inclusion within health benefit packages, but alongside is how do we strengthen the health system to deliver better in terms of quality of care, taking a primary healthcare approach.
Thanks, Viloshni. I'm checking if anyone else wants to jump in on this, or we can move on to the next question. It links, I think, as well to what we've been discussing now, but in particular, there's a couple of questions around how abortion care can be delivered in and included in UHC packages in some more restrictive settings without leaving anyone behind. And I wonder if anyone, Jagadish Forrest, please go ahead.
Right, thank you. I think this is a very pertinent question, and if abortion is seen as a stigma and a discrimination point of view, then it will be difficult to initiate services, but there are solutions. First of all, I think to increase the abortion services, for the country like Nepal, we have pre-abortion care services. So those public health facilities which offer abortion services, they provide in free of cost. But even if it is free of cost, there are, because of different factors, women and girls, they are not coming to the facility. For those areas, we need to have some sort of contextual programs. Like, for example, we are trying to identify what are the factors, social norms, hindering to the uptake of the services from the facilities. We are trying to identify the driving process and the restrictive process, for abortion services, and utilizing, capturing those information. We have developed the agency building activities, like not only for women and girls. We need to engage with like in-laws. We need to engage with men and boys, for friendly services. And we also need to work with some of the champions, Srhr champions, to advocate with and increase the services in such settings. So we need to have a balance between demand and services, addressing the harmful social norms and practices. Thank you. Over.
Thank you very much. That's yes, just that critical balance between the demand side and supply side, and really addressing the multiple levels and barriers that can restrict access beyond just including it in the benefit package. So thank you for that. I have a question here. Many of you have spoken about. I'm told I have one question left. I might be cheeky. I might do two. Because many of you have spoken about, of course, the importance of taking an intersectional approach and of addressing SRHR for across the life course. And we have a question about how UHC is serious in targeting SRHR for older women above 50. We do know targeting services for older women reduces occurrence of NCDs. So I do want to give someone a chance to respond to that question briefly, and then I'll do the last one. If that's okay with the organizers. Anyone want to jump in on this? Do you know Dr. Guna? Yes, please go ahead.
Thank you, Michelle. Basically, yes, if we just refer to the reproductive health and reproductive cycle, maybe, yes, as you mentioned, we may miss that group more than 50 years, and the problems and they are facing after the 50 years that can be missed out. So Nepal's health policy has articulated is a life course approach, and within the life course approach, we can also implement the sexual and reproductive health services and other right issues. So basically, this issue has been raised in different forum in Nepal, and even in the policy dialogue, it has been discussed. So I think based on our new approach, that is a light course approach, I think we need to redesign our service delivery points, and we have to redesign our programs towards the achieving this area that we left this group. So we should not miss any group during this course life course approach. Okay. Thank you. Over to you.
Thank you very much. Thank you, Dr. Guna. All right, so I'm going to go for the last question, and this is a tricky one. So we have this framework to integrate SRHR and UHC. It's quite ambitious, a comprehensive set of interventions at a time where resources are constrained. They will always be constrained, but there is a bit of a question on how do we achieve this? In short, how do we do it differently? The question says that the same song of holding governments accountable has been sang for far too long now, don't you think? So I'm going to, does anyone want to take on that question? I think there have been some provocative and more disruptive ideas of how we can do things differently already. But perhaps Melania, I know would you like to jump in?
Oh, yes. I would say that SRHR, UHC, they can work together, because when we talk about UHC, we are talking about universal, and we are talking also about health and the coverage. And when we talk about SRHR, we are also having the aspect of health. So if we can have policies in place that can bring this together in different countries, in different counties, if we are talking about it in Kenya, we have to bring them back together. How do we sit with policymakers to make decisions? Yes, we need to hold government accountable. Yes, we'll sing this song from ear in, ear out for them to understand that actually this is what people need out there. But when we say that we've sung the song so many times, people can only understand the chorus when you repeat the chorus over and over again. But if you say it at one time and say that you are tired of it, there will be no implementation on the same. And people will not take you serious because they actually don't know what we all need. So I'll say if we can have policies in place and implementation of those policies, because at times we have good policies, we have good agendas, we have good acts, but at the end of the day, you find that there's no implementation on the same. So our question will be, how do we put this in place so that it is implemented at different levels, from the ground level to the high level, without us having that conflict, and even without us feeling like we are begging for services and we are begging for the information. So there's also need for us to pass information in different levels. Yeah, so that will be my take. Let us have policies and pass information.
Thank you. Thanks. Thank you so much to all of you. And thank you for all the questions that have come in. We can't take them all, but I hope we've tried to address some of the range, at least, that was out there. And we are now nearing the end of the session. So I want to turn back to our panelists and ask each of you for your 1 minute take on this one question. What would you say is needed between now and the next UHC high-level meeting in September 2023, so that there is demonstrable progress, both for SRHR and for CSO engagement? So you've got 1 minute or less. I will go with Melania. I'll let you go first. So we'll start in reverse order.
Okay, thank you, Michelle. For my 1 minute, I'll say we still have a long way, and there's need of inclusion, especially persons with disability. I don't know if we had a sign language interpreter in this session. There's also need of for us to have information on when and how Do we engage other people? Yes, I am privileged to be here today, but we have also young people, adolescents, to be in this space so that they can also air their views. Because when I am speaking, I'm speaking for them, but we need them to be in the space so that they can also speak for themselves. We also need to have the LGBTIQ involved in the process so that it's not a one-sided. I might talk about intersex, I might talk about trans, but who is talking about the LBQ persons? So that means we need inclusion and diversity in whatever we are doing. Thank you very much.
Thank you. I think that was less than a minute even. Dr. Guna, do you want to go next?
Okay, thank you, Michelle. Yes, thank you so much. I would like to draw 5 messages as a takeaway from today's discussion. Number 1, the voices from the community people play a crucial role to sensitize the policymakers and the public concerns, such as sexual and reproductive health rights, adolescent-friendly services, and other minorities focus programs. Our experience shows that the such voices can be reached to the policymakers through continuous advocacy in the form of campaigns, dialogues in different forums. The voices raised in advocacy forums should be backed with evidence. Without evidence, maybe that may not be implementable. And policy options should be presented to the policymakers. Option 1, option 2, option 3, which could so that the policymaker can choose any options. The high-level political commitment is the essential substrate for the reform to take place. So continuous advocacy, continuous campaign, continuous dialogues is necessary to make it happen. Based on the chosen policy options, the specific interventions should be designed considering the local context. Societal acceptance and cost factor is always there. So we should engage key stakeholders, including the targeted beneficiaries, since the very beginning of the policy formulation. This will create ownership and facilitate smooth implementation. For the sustainability of the program, adequate domestic funding is vital. Finally, we should have a strong monitoring and evaluation mechanism to judge whether our interventions are well implemented, reaching to the targeted sections of the society. For this, we need disaggregated but robust data to inform the necessary adjustment in program and intervention. Thank you, Michelle. Over to you.
Thank you. Thank you very much for that very comprehensive action agenda to take us to 2023. Jagadishwar, do you want to go next?
Thank you, Michelle. I think it depends on the country and where we are in terms of development of universal health coverage framework and the civil society engagement. It depends on the country context, but we need to focus on 3 major areas. First and foremost, we need to have a framework for universal health coverage, like where the country want to go, because we already have many of the countries, we already have a commitment signed for universal health coverage and Srhr, and there need to be regular review and reflection of the existing policy environment and political commitment, and CSO engagement for civil society, for Srhr, so that we can achieve better result in a short period of time. And the last one is revitalization of the health system for quality and equitable Srhr services. Equitable meaning it is not only for people living far flung, but people with disability, adolescents, LGBTI. So different kind of people need to be need to feel that they are receiving Srhr services, Thank you. Thank you. Over to you.
Thank you very much. Veloshni, do you want to go next? And then
that's a hard act to follow, Michelle. All of them.
I know.
But I'll give it my best. I mean, I think I think we need the next high level, the UHC high level meeting in 2023 is an important benchmark. But for real and transformational change, our vision needs to extend beyond that. And we need to have a bigger vision for transformation. But in the immediate, I think we need to step up investments in several areas, and some of which Dr. Gunnar, Jagdishwar, and Melania have all covered already. I mean, I think, but I'd like to highlight three. The one is strengthen the evidence base in its broader sense, including best practices that captures the lived experiences of all those that are marginalized and vulnerable. And I think this is thinking about evidence in a much wider sense beyond research-based scientific evidence, but that's also experiential. And I think that's what we really need to be able to kind of bring to the fore, the experiences. I mean, on the chat, there was an input from a person in a refugee camp. And I think in terms of access to services or lack of access to services. So how we think about the evidence base. Secondly is advocating and, advocating for inclusion of comprehensive SRH services in benefit packages, but also addressing the legal constraints which prevent them. And for this, we do need evidence again. Evidence is absolutely critical, but we need priority setting processes that are transparent and that are inclusive, that are not alienating, and that go beyond cost and economics to include gender equity and rights. And thirdly, I think, which is possibly the most important, because we can't build the evidence, we can't build the inclusion of SRH services based on evidence if we do not create safe space for constructive dialogue between all relevant stakeholders. So the starting point for me is, and I think which has been articulated so well today, is the importance of safe, inclusive spaces. And I think that's been well demonstrated from our colleagues in Nepal. So thank you.
Thank you. Dumi, go ahead.
Thank you. I think two main things, and I mean, it's 2 years away, so I really advocate for institutionalizing and socializing participatory health governance mechanisms guided or embedded by the resources CSEM has shared, and I think these are key to creating resilient health systems for UHC, and these resources, these resources should not be left to technocrats, boardrooms or baseline reviews, but they should be applied to ensure all women and girls, gender non-conforming and non-binary individuals like myself are actively included and participating at all stages of SRHR and UHC interventions. Secondly, and lastly, we must challenge the disruptions, defunding, and deprioritization of SRHR services and care. This is universal, regardless of jurisdiction or income country status. And this means advocating and advancing feminist leadership. For example, questioning who's not in the room and who's not included. I think this is critical for ensuring grassroots, outlier, poor, and disenfranchised groups are included, engaged, and enabled to thrive in spite of the challenging socioeconomic challenges they have had and continue to face, pandemic or not.
Fantastic. Thank you all so much. I think we have a plan to get us to 2023. Many thanks. We have only very few minutes to wrap up now. So I'm going to try. I'm not going to attempt to summarize our discussion. It's been too rich. And I'm glad it will all be made available and others can have more time to digest it. But my primary reflection and takeaway is fundamentally the heightened urgency of this agenda to integrate SRHR and UHC and the power of feminist civil society across the world in all its diversity to really drive change for the realization of SRHR in UHC. And I think it's at a time when spaces for civil society are shrinking in many settings, resources are further constrained by the pandemic, and the speakers really have all underscored the critical roles and the range of roles that civil society can play and how the governments can work with them to deliver on this mammoth UHC agenda. So I will just we have the key recommendations here. Just my quick takeaways, I have 3 of them. One was the social participation, the importance of social participation and diverse representation, which really makes health systems more equitable. And these mechanisms need to be safe spaces that are institutionalized and resourced. We've also spoken about civil society actors as experts and producers of solutions of local knowledge, learning to achieve health for all. And the expertise, I think, well, as an academic, I always find, I'm always in awe at the expertise of civil society in policy advocacy and in their political astuteness that I think many in the health sector also, may not necessarily have, but need to influence political decisions and accountability for health goals and UHC. I'll not go through these recommendations here, but just so you know, these are just to reiterate really that as governments and other stakeholders gather, we need to stress that now is the time to reinvest in SRHR as essential, not optional, and as central for UHC. So tomorrow, September 30th, the group of Friends of UHC and Global Health, WHO and UHC 2030 are hosting an event to officially kick off the road to 2023 for the high-level meeting on UHC. And these are the recommendations we hope will also be part of that conversation. The importance of engagement that centers on those who will be most impacted by policies, the importance of UHC being designed intentionally to reduce inequalities, to address and to respond to the diversity of women in all their intersecting identities, and with special attention to those who have been pushed furthest behind by this pandemic. And of course, the importance of services that are free of stigma, discrimination, coercion, and violence, and that are truly integrated, quality, affordable, accessible, and acceptable. So we need implementation, we need funding. The speakers have said it much better than I could, and it needs to be rooted in equity. Make sure we reach those that are furthest behind first, that we build up resilient health systems that really reduce gender inequalities and address these gaps that have continued to widen during this pandemic. If you could go to the next slide, just want to let you know all resources, event slides, and the recording will be shared with participants. As you know, the speakers have shared some very practical examples and very practical tools to support the efforts to advocate and to ensure renewed focus and investment in SRHR as part of UHC packages and plans. And we also encourage civil society partners to join the Alliance for Gender Equality in UHC and the UHC 2030 CSEM to engage with others in this advocacy effort towards 2023. And we, of course, encourage governments to examine their current UHC packages and consider whether SRHR is sufficiently addressed and what concrete ways civil society might be able to be brought into the process. I will just end with my word of thanks, sincere thanks and gratitude to all the speakers today for your insightful and thought-provoking remarks and your very practical contributions. Thank you to all participants for joining us and for contributing your questions and your comments and your particular experiences. And a big thank you as well to the co-organizers for bringing us all together here today. This has been an extremely timely, inspiring, and action-oriented event. So let's keep working together in solidarity towards 2023, but also beyond, because this is a big agenda ahead of us. Thank you all.